Good evening, everybody. I'm Andreas Skolarikos. I'm professor of urology in Athens, Greece. And for today's webinar, the topic is the follow-up of the stone patient. We are very happy that we have an esteemed faculty with us tonight, all working for the EAU guidelines. Last year, we managed to do a lot of work on how we should follow up our patients with stones. And what you will see, the vast majority of the talks are the result of two systematic reviews that we created within the panel group of the guidelines. I hope that you will enjoy. Together with us are Rob Geraghty from Newcastle, the Freeman Hospital from UK, is Lazaros Tzelves from the second department of medical school, the urological department in Greece, is Riccardo Lombardo from Rome, Italy, San Andrea, and Professor Somani from Southampton. So I would like you to enjoy, because I think it's very important to have your active to be active within this webinar. You can ask questions as many as you like, and at the end, we will discuss these questions and we will try to reply to all of these if possible. So Rob, thank you for being with us today. You will start with the follow-up of small asymptomatic renal stones. I think it's an interesting topic, and the podium is yours actually.
Thank you very much, Prof. So good evening, everyone. So I'll be talking about the follow-up of small asymptomatic renal stones. So I'm an associate member of the EAU guidelines panel on urolithiasis, but I have no other conflicts of interest. So the follow-up of small asymptomatic stones is a controversial area. Should we or should we not intervene? And if we're not intervening, for how long should we follow up the patient? This is becoming an increasingly pertinent question with the reportedly high prevalence of asymptomatic stones. The key information needed to aid our decision-making is data on the natural history of these stones. Unfortunately, there is a paucity of data on this subject. What papers there are often use different cutoffs to define small, whether it be less than 4 or 5 millimeters, with a variety of follow-up imaging and outcome measures. So I always think with these patients that there are two conflicting mantras: leave no stone unturned, and you cannot make the asymptomatic patient better. So I hope this talk will guide you in your practice as to how you manage these patients. So first of all, what does the guideline say? Well, given the poor data, the guideline is handicapped and therefore cannot make any recommendations on the follow-up of small asymptomatic renal stones. So I just briefly wanted to draw your attention to this section of the guideline. So in patients with asymptomatic stones, I have highlighted the potential indications for stone removal in red. All patients should be assigned to a low or high risk group as per the guideline. And by removing these patients, as the recommendation is to intervene, you are left with stone growth, which implies that you have followed up the patient for a period of time, and patient preference. So there are two studies I'll use in this talk to guide decision-making. Both are systematic reviews and meta-analyses. So the first is by Catherine Lovegrove, who looked at both renal stones and asymptomatic fragments, with the assumption that these behave in a similar way. In this study, 3 key metrics were identified: intervention rate, symptom development rate, and emergency admission rate. So the first of our studies uses a cutoff of less than 5 millimeters on study-defined imaging. So most use X-ray or ultrasound for fragments and non-contrast CT for diagnosis of renal stones. You can see that the intervention rate peaks at around 36 months before tailing off. The symptom development rate rises over time, and emergency admission is around 1/5 of patients, although this particular metric is limited by very few studies. So our second study is by the guidelines panel, and you'll hear more about this study later. but this was focused entirely on post-treatment fragments. Again, there are three key metrics: intervention rate, as previously, disease progression rate, which includes both stone growth and symptom development, and spontaneous passage rate. Just as a quick caveat, both of these reviews suffer from quite high heterogeneity, and therefore the figures that I'm presenting in this talk are the best evidence we have at the moment. So this second study uses a cutoff of less than or equal to 4 millimeters. Again, intervention rates are shown to peak at around the 3-year mark. Disease progression was heterogeneously defined within the studies, but seems to be around a third of patients by 4 years, while spontaneous passage rates decline over time. So you've heard the evidence. The key question now is observation or intervention. So as we've said, there's limited evidence for the management of small asymptomatic renal stones, and therefore very limited guidance from the guidelines. Therefore, this decision should be made in conjunction with the patient. They should be counseled about the risks of not intervening, as well as those of intervention. And this will allow the patient to make their own decision regarding what they would like to do about their stone. So in the absence of other guidance, this follow-up algorithm was developed by the guidelines panel for follow-up with patients following intervention. Given the assumption that asymptomatic renal stones and post-treatment fragments behave in a similar way, we could use this as a guide should the patient wish to be observed rather than have an intervention. So this is just a very quick clinical example of how you might approach someone with an asymptomatic small stone. This is a 60-year-old man with a background of hypertension who presented with visible hematuria. His flexible cystoscopy was normal, but his CT showed a 4 millimeter left lower pole stone, which on plain X-ray was radiopaque. He reports this is his first stone and he has no family history and no other past medical history. The full CT shows no abnormal anatomical features. So what should we do? So first, I would risk stratify this patient. He already has hypertension and he is older, therefore he's more likely to have metabolic syndrome. We therefore need to check his height, weight, blood sugar and lipids, along with the usual tests for stones, which include calcium, urate and renal function. So these all come back as normal and his BMI is 24. So as he's low risk, I would then counsel him about the risks as we've already discussed. He opts for observation. So I would follow this gentleman up as per the guideline on post-treatment fragments. So his stone is unchanged at 6 and 12 months, but on his 24-month X-ray, which is the next time point at which you would do imaging, his stone looks like it has grown to 7 millimeters from the original 4. So what should we do now? So there's been a significant stone growth, which would now prompt me to intervene, and I would assess him for suitability for ESWL, including both stone and patient factors as per the guideline. Providing he is suitable for ESWL, I would offer him the choice of either ESWL or ureteroscopy and advise him on the likely success and complications of each, so he can make an informed decision. I would also reassess his risk status, as he may well have developed metabolic syndrome in the 2 years since we last assessed this, which would prompt closer follow-up as per the follow-up algorithm. So in summary, there's no clear guidance on the follow-up of small asymptomatic renal stones. The key is to counsel the patient about the risks of doing nothing versus intervention. If they choose observation, then use of the new EAU follow-up algorithm for small post-treatment fragments could be a useful guide. Thank you for listening.
Thank you, Rob, for an excellent talk, I would say, and most importantly, for raising the questions, because the questions you have raised are really, really very important. I would ask, because we don't have questions and answers still, but I would ask you very briefly, why do you think we cannot give on this topic a clear-cut answer to our patients and, of course, to the urological community?
I think the key here is the lack of evidence. We have very few studies on the follow-up of small asymptomatic stones. And certainly, we see intervention rates peaking at around the sort of 2-year mark, which implies that people are intervening in these sorts of smaller fragments, and certainly the 2 to 4 millimeter fragments. So we don't have that long-term follow-up data. And therefore, who's to say what would happen to a particular individual over time? We just don't know.
And if I ask you, Rob, let's say, don't do any follow-up, and let's wait when the patient becomes symptomatic. Is there any rationale to not to do anything? Because, if the patient is very young, the rationale for following this patient is very easy to understand. He has a lot of years in front of him, but if he is an elderly patient, can we reply to this question? Don't do anything until the patient becomes symptomatic, no follow-up, no imaging. And please clarify the imaging, because X-rays are always X-rays.
Indeed. So I think in the example you take, if a young person came, with a stone, I think the key for any stone form is risk stratification. If they're going to be a high-risk stone former, then we need to follow them up more closely. And if they're low risk, then we just don't know what will happen to them in the future. So only about a third of patients become symptomatic after 4 or 5 years. We don't know after that if all of them become symptomatic, or if it's just that third who remain symptomatic. Yeah. So it's a question of what would we do. If it were me, I would probably want to be followed up for at least 5 years, as per the data. And then I can, if I remain asymptomatic at that point and my stone hasn't grown, I'd probably say, I'd like to go, please.
We may have also to underline that imaging means also an ultrasound scan once in a while, as we discuss it in the framework of the guidelines. So it's not always something which gives radiation exposure to our patients. So follow-up with an ultrasound is cost-effective, I would say. Does not cost a lot, does not cause a lot of trouble. Yeah. So thank you, Rob, anyway. And I will welcome Lazaros. Lazaros is working in Athens, as I said, Tzelves, Dr. Tzelves. And it's quite an important question whether we can discharge to some point our patients from the follow-up. Lazaros, we are all ears.
Good evening, everybody, and thank you for this opportunity. Well, my topic is on when to discharge the patient from follow-up, imaging follow-up, after having a definitive treatment. This is my conflict of interest. Well, as an introduction, we know that urolithiasis has an estimated prevalence of nearly 11%, according to recent studies. And recurrence rate is quite high at 50% in 5 years for the general population. And more recent studies report that for the first-time stone former, up to 1 out of 4 in 5 years finally experience a recurrence. Again, what is important is to underline that pain, infection, or sepsis, chronic kidney disease, and accumulating ionizing radiation exposure and decreased quality of life come along with this clinical condition. As underlined before, no standardized follow-up plan exists, and most urologists follow only consensus. Regarding radiation exposure, we have to highlight some facts. Up to 20% of patients exceed the annual threshold of radiation, with a mean 1.7 CT scan per patient during the first year follow-up, and this is quite important. And although deterministic effects from acute high-dose radiation exposure is practically a non-existing danger for these patients, stochastic effects, namely mutations and cancer, can actually occur from accumulating exposure. There are studies that report that 1 to 3% of yearly new diagnosed neoplasms are linked to radiation exposure. Recognizing all these facts, the EAU guideline urolithiasis panel performed a systematic review on the role of follow-up versus no follow-up after treatment, but no comparative studies came up according to our search. Then we gathered the data from all studies with follow-up plan of more than 3 months after treatment, and we defined after consensus that we need to find the 80 and 90% stone-free rate during the follow-up, and we chose these cutoff points to decide at which time point they were met in order to guide clinical decision-making. So the facts about this systematic review was that stone-free rate was defined in trials using several imaging modalities. Residuals were separated according to size of equal or less than 4 millimeter, and those larger than 4 millimeter. Importantly, we used the term general stone population, which actually is a mixed stone population as used in eligible studies, and high-risk patients were those with existing metabolic abnormalities. And findings, as presented below, are based on a meta-analysis of proportions. First, regarding stone-free patients, we analyzed data from nearly 5,500 patients, and according to the heterogeneity, the pool stone-free rates that were calculated at several time points and the imaging method used, we proposed the following acceptable time points to discharge patients from imaging follow-up. To achieve an 80% stone-free rate, we should follow up patients up to 3 years, and for a 90% stone-free rate until 5 years. Specifically for radiopaque stones, we should follow them up for 2 years using X-ray, and for radiolucent stones, up to 3 years using an ultrasound with or without a CT scan. Regarding residuals of less or equal to 4 millimeter, disease progression, meaning mainly increase in size, was 34% after 4 years of follow-up, interventions 29%, and the spontaneous passage rate was 34% after 3 years. Considering all these facts, we propose that such patients could be either followed up for 4 years or treated according to patient preference and symptoms or complications that may arise during the follow-up. Regarding residuals larger than 4 millimeter, the disease progression rates were quite high at 67%. Intervention rates were very high, up to 100%, and spontaneous passage occurred at less than 20% at 3 years. Therefore, we propose that intervention should be the plan for these patients unless they dictate otherwise according to their preferences. Finally, regarding high-risk patients, which are again patients with existing metabolic abnormalities, we separated them in stone-free and those with residuals, and those who were taking preventive treatment versus those who were not taking preventive treatment. Calculating all these pooled stone-free rates and stone growth rates, we propose that follow-up for 4 years should be performed in those other drugs and consider discharge from imaging follow-up for those that did not progress either with symptoms or stone growth. For those who were not under preventive treatment, we propose a follow-up for 4 to 10 years, but consider a lifelong follow-up because data were very scarce. We should also highlight the limitations of these studies. It was a systematic review based mainly on observational studies with a great heterogeneity in most of the analysis, and there were several definitions of stone regrowth, disease progression, stone-free status, and several imaging modalities were used for follow-up. Again, a mixed stone population was defined, and it contained several stone types, stone size, and locations. And importantly, data spanned the 50-year period during which several advances are made, which permit us to treat patients more effectively. Finally, we used the cutoff for clinically insignificant fragments of 4 millimeter, which was used in most studies, but this is under debate recently. Summarizing the facts, I use an algorithm as shown in the guidelines. So after the definite treatment, we should separate the patients to stone-free, those with residuals, and the clearly high-risk patients with metabolic abnormalities. Stone-free patients could be followed up for 2 years using X-ray when having a radiopaque stone, or 3 years using X-ray and ultrasound when having a radiolucent stone. In order to achieve a 90% safety margin, we should follow them up for 5 years. For patients with residuals, those with residuals equal or less than 4 millimeter or dust should be followed up for 4 years or intervene according to their preference, and those with larger fragments should be scheduled for a reintervention. Finally, in high-risk patients, follow up for 4 years and discharge if they do not progress should be done in those under preventive treatment, while those under drugs should be followed up at least for 10 years. Of course, we have to consider a lot of clinical information when we deal with these patients, and this should be a priority adjunct to the guideline recommendations. Thank you very much.
Lazaros, thank you so much. I think that Lazaros and all the associates in the guidelines panel, they have made really a very good job on analyzing all the data for the guidelines. Lazaros, you did all the difficult task of giving us the numbers. But the last algorithm that I think it's the most important, that we do have it in the guidelines. Can you give us an example? Let's say we do have a patient with a radiopaque stone, and I ask you in your office as I come to see you, now what, doctor? You made the flexible ureteroscopy so terrific. I'm very happy, and I have no stone residuals. For how long should I be on your hands being followed up?
So if this patient is not, of course, we should have the clinical information beside the surgical information. We should know if this patient relies on the high-risk category or not. If not, and we have just a stone-free patient after flexible or PNL, we should follow this patient using an X-ray, considering this is a radiopaque stone, for at least 2 years to be, let's say, safe that he or she would remain stone-free with an 80% accuracy, according to our findings.
Then we imply that he will or she will come back if she or he becomes symptomatic.
Yes. Of course, if patient wants to be followed up for a longer period of time, that's under discussion. And again, as you very correctly dictated, we should discuss the pros and cons of radiation, and we could use for a longer time period an ultrasound if that is desired.
So main message of your talk and the numbers that we have given is that probably we should individualize the follow-up and the timing to discharge our patients based on their clinical scenario, and explaining that unfortunately there is not a clear-cut answer for these for our stone patients.
Yes, and that's what's the problem with all the studies existing out there, that every patient has a very broad category of characteristics, namely the stone type, comorbidities, anatomy, socio-economical factors.
And one question, because we don't have a lot of questions for you for the time being, one question is regarding the cutoff of 4 millimeters. We can see some studies saying that even 2 millimeters residual stones are really important and may cause trouble to our patients. Why we selected as a guideline panel the 4 millimeter and not the 2 millimeter cutoff point? Can you please explain that for us?
Yes, we discussed a lot, and because most data came for the 4 millimeter category, we decided to use this cutoff point. And there was also a study with they named it DUST, but the findings were similar. So we decided to group them together. But of course, this is under debate in the literature.
And last but not least, I think we got a very good message from the studies regarding the high-risk patients being on medical treatment and taking their medications, because I think it's very easy to understand that if a high-risk patient is not under medication, then he will relapse eventually. So give us the message for those patients that are being followed very strictly and are being they are taking their drugs.
Yes, of course, it is very important to follow them up regarding their treatment, namely if they take it and if they develop side effects from the drugs, which is very common, and regarding their urolithiasis condition. If they are under drugs, if they are not progressive, we can consider stop follow-up at some point, but if they are not under drugs, they most commonly relapse, so we should follow them up carefully using both imaging and metabolic studies.
Okay, thank you, Lazare. And I welcome Riccardo Lombardo, one of our associates in the guidelines panel. I think Riccardo, and guys, sorry to say, I think he will give the most important talk for tonight, because he's although it is a consensus, as Riccardo will say, I think it's very, very important for our clinical practice. Riccardo.
Thank you, Andreas, for the presentation. I think as well that I got this important task to talk about how, and especially how often, to follow up patients after definitive treatment. So I will start saying that we will actually, first of all, we will define who we are treating, then how, then we will see when exactly. So, and then I will guide you through our process to let you understand more clearly what we did and how we reached to that complicated algorithm that we developed all together. It was a very comprehensive work with the best evidence we got from the literature, even if we will see it's not that big of good evidence. So first of all, we'll see how do we really define patients. Normally we have two types of patients, especially in the general population and the high-risk patients as defined by the EAU guidelines. However, we will see that unfortunately this kind of classification is not always possible, because very often studies and heterogeneity does not allow us to clearly define patients this way. Then let's talk about how can we follow up patients. This may be quite simple, but we will the characteristics of the different types of imagings that we may use in following up patients. So our options are obviously X-ray, ultrasound, and CT. So let's go through the different characteristics and the advantages of the different types of imagings before analyzing the data. So probably for what we should start by saying is that the gold standard is probably the CT. This why? Because X-ray may have some advantages, especially we may say that it's a simple technique. It's widely available, so we can find it in all kinds of different countries, so you don't need a lot of technology, and it is a low-cost technique. This is the first. The disadvantages is that the accuracy is not that high. It may miss radiolucent stones, and we may have some radiation, even if not as high as we may have with CT. So standing to the available evidence, the sensitivity is around 45%, and the specificity is around 77%, standing to the available literature. Ultrasound, probably the most widely available technique we have. It's simple, depending obviously on the learning curve of the technique. We may find it all over the world. It is a low cost, and most importantly, an ultrasound follow-up means no radiation. So this is a big advantage for what it means for this talk. It clearly depends on the physician performing the ultrasound, but we may miss some stones depending on also on the type of ultrasound we have in our department. And as we can see, the accuracy may be very different, especially sensitivity is not very high, specificity is quite good. And this is what we have from the literature. So CT, as we said, may be considered like the gold standard. The problem and the big disadvantages of CT is radiations, cost, and maybe not available in all settings. So especially if patients and the overload of the radiation departments, as seen in many of the recent literature on the subject, may limit the applicability of the CT, especially in the emergency department, and even more if we have to build a follow-up for patients in this setting. So low dose CT accuracy by the mean is 93 and 97%, so way better than the ones we talked about before. So actually, we have to always make a balance between benefits and harms, especially in this kind of decision. So the problem is when actually we have no evidence from the moment, clear studies comparing different times of follow-up. So this was a main problem in our review. So let's go for the data. What is the data out there? Let's go for the big data of this talk. So what we did was a systematic review of all the available evidence regarding follow-up. So we did a very wide search, especially because when you have randomized clinical trials comparing two types of methods of follow-up, this is easy to perform a clear recommendation, while when studies are of poor quality, it's better to have more data on the subject, and especially for the work done by the EU guidelines for this instance. We performed a risk of bias assessment using the cognitive evaluation risk of bias tool for randomized controlled trials and Castle Tower for observational studies. And as you can see, for observational studies, we did a specific risk of bias assessment. And so we will go back to our different questions. So who? In this, after analyzing the different studies that were a lot, we had actually to adapt the risk categories. We couldn't use the ones we defined at the beginning of this presentation, especially because we have, stone-free patients are defined by the study. So normally it's the general population we are actually talking about. And we actually didn't have separate data for low and high risk patients. The most important thing to underline is that high-risk patients are defined as stone-free patients with a known biochemical abnormality. So this is not the definition we find in the guidelines, so this is important to underline. And then we defined, this is something that Lazaros already talked about, and we talked about in the previous presentation, is that residual fragments, we define it at less equals to 4 millimeters and not, or more than 4 millimeters. So this was actually the data. I tried to pull it up. So we actually analyzed stone-free rate for the general population. And as you can actually see, just not to take too long, there were some data. These are mean follow-up, actually. And as you can see, the ranges are pretty wide, but we can see that the stone-free in the general population at 1, 2, and 3 years may be quite high for these categories. And that's why we actually, in the previous presentation, we can discharge with some certainty patients after a certain number of years. Then we had some data on these patients with 5 millimeters, less than 5 millimeters. And in this case, we actually extracted data for spontaneous expulsion rate and rate of the residual growth, which are the two types of important data we need to establish which is the best follow-up in these patients. So as you can see, once again, the ranges are very wide, and we can find in the first years quite high, the spontaneous expulsion rate is quite high, but by going through the years, this goes down, and the rate of residual growth can be quite high even at 5 years. Then we did a separate data, and as well we found that these patients may have a very quite not insignificant spontaneous expulsion rate, as well as the rate of residual growth. Then actually we have some data on residual fragments of more than 4 millimeters. These are data is not available for all time points. What is quite clear from this slide is that these patients are at very low rate of spontaneous expulsion rate, and the rate of residual growth is as high as 77% at 3 years. So now we go to our questions, how? So how and when actually there is no evidence as meaning by direct studies examining patients, and especially at which time points. So what we do normally when the evidence is not there, the high quality of evidence is not there, in the literature we make a consensus. So what we perform is based on the data we had several discussions trying to understand and to make, based always on a benefit to harm principle, trying to elaborate a diagram to help urologists to follow up patients, especially because if you go through the literature, especially benign diseases have no clear follow-up as oncology diseases. So we used a modified Delphi process, especially because a Delphi process normal more physicians than we did. But what we did is that we performed in a small group the analysis of data, and then we developed some questions to establish which was the best decision on the. I will come back to these concepts on when, how, and who to follow up. So once we developed some questions, we then all together, the guidelines panel, answered the questions to define the recommendations. So we will stop by this slide for a second. So the first question we developed is if patients should be followed based independently of the intervention performance. So the first thing is that should we follow differently patients undergoing cutaneous nephrolithotripsy or urolithiasis or ESWL? And the consensus said that all the patients should be followed the same way. So we set a cutoff of agreement superior to 80%. And this was the first big questions that helped us out to develop one and one only diagram for all the patients. And this simplified a lot and simplifies the role of the clinician. So thereafter, how often should we follow patients? So all the patients should be followed every 3 months. This was no agreement. So we actually, the next question was agreed by more than 80%. And so the patients should be followed at 6 and 12 months and so on. Then going to which type of imaging, something that we talked about before, we asked first straightforward questions was if we should use the gold standard at every time point. And the consensus was that this was not, so there was no agreement. So we had to develop other proposals for the panel. So we decided the type of inaugural data, and an NCT-CT should be performed at 6 months was another proposal. And once again, this was not accepted by the panel, even if it might be reasonable. Thereafter, we agreed all together that actually NCT, so non-contrast enhanced computed tomography, is not necessary actually to follow a patient. This was a big and important consensus because it will have probably a very big impact on everyday clinical practice. Thereafter, we came to the consensus that KUB or ultrasound should be decided based on clinician preferences and on stone characteristics. Then we had actually high-risk patients with, as we said, we might not choose the type of follow-up, meaning by the type of so actually, if patients with a known metabolic abnormality should follow metabolic follow-up, this was an overall agreement for all the panel. And the final, and to reach the final algorithm, so I can go to the end. So intervention actually was, the agreement was that intervention was needed for residual fragments of more than 4 millimeters. This was actually our final algorithm, which was quite complicated to reach. And as you can see, we have the 4 different types of patients you may have, and you may follow them more or less closely depending on the category. So to come to an end, which are the limitations of this study that we actually, that's something that already Andreas underlined, Professor Skolarikos, that actually we have no real data on patients between 2 and 4 millimeters and less than 2 millimeters. The cutoff of 4 millimeter was decided based on the data we had. And another limitation is a large heterogeneity in stone-free regrowth and disease progression definitions. Another important limitation for this analysis is that very few studies had different time points reported. So data is based mainly on actually mean follow-up. My conclusion is that implementation follow-up in urolithiasis patients is mandatory, and that the present algorithm represents a benefit to harm option and the well-designed studies are needed on the subject to improve our algorithm. Thank you very much.
Riccardo, don't leave the presentation. Can you stay there, because this is the most important message that we can give. As you look, everyone, first of all, we have some questions and answers, but we are expecting more questions from your side. So please feel free to ask questions. We are quite proud actually about this algorithm. And the question now, Riccardo, is this is a consensus that we made. Why are we so bad that we cannot extract data as a panel? Are we so bad as urologists in general that we don't present the data in such a way that we can create algorithms? Or is the diversity of the stone patient that is so difficult to group our patients? So I want your reply on this.
Thank you. Important question, meaning that the first thing I have to say is that normally benign diseases receive a very poor follow-up, meaning that we follow up oncology patients very close because we have to follow them because of risk of recurrence. And this should be our way in benign diseases. So the first statement is that actually, because it takes a lot of effort to follow up patients, probably researchers don't take a lot of time to follow up. And that is clearly evident by the kind of studies we find on follow-up, and very little of them had different follow-up time points. That's the first thing. Second thing, we extracted a lot of data, but as you clearly said, stone patients are very different between them. So as we to have a clear high risk population, and that's something we couldn't do. So that means, I think that the big message for everyone is that there is a lot of space to do very good studies in this area.
Okay.
This is clear. And the other...
Sorry, yep,
no.
Please go on.
And the other good thing is that, especially by analyzing and by the consensus, we have a very important panelists that can give their contribution, is that following up patients with ultrasound or X-ray is not that difficult. So I think that it will be easy to implement such a diagram. We have, this is important, I think.
Okay, so if I may, Riccardo, travel our listeners, our people that they are joined to this webinar. I think, guys, this is a very important algorithm, as I said, that we created. So if you operate a patient and your patient is stone-free and it belongs to a general population, then 6 and 12 months imaging. Imaging means KUB or ultrasound. And then at the 36 or 48 months, or 60 months, based on the data and the numbers that Dr. Tzelves showed, you can actually discharge the patient after canceling the patient. If the patient belongs to the high risk, or if the patient has small stone fragments and are belonging to the high risk group, then you need to do imaging, metabolic follow-up, and treatment monitoring, meaning see the side effects, which are very important, I think. It's an important message. If the patient has fragments less than 4 millimeters, go back to the algorithm, and they are at low risk, I think imaging is very important to be done, performed more oftenly. And again, imaging means KUB or ultrasound. If your patient has fragments more than 4 millimeters, based on our results and based on the results that Dr. Tzelves, the numbers that he presented, we recommend reoperating. But if the patient does not go for reoperation, then imaging is needed on every 6 months, which I think is an important message. Imaging, again, as I said, is KUB and ultrasound or ultrasound, but it is CT scan if you need to intervene. I think this is also, Riccardo, is an important message. Just for the sake of time, Riccardo, thank you so much. I would say that it's a great honor to have Bhaskar Somani, Professor Somani, with us and tonight, but also in our guidelines panel. And Bhaskar will discuss about the preoperative and postoperative imaging for stones in children, which I think is also very important. Bhaskar, we are all ears. Thank you.
Thank you so much, Andreas, and thank you to the guidelines panel. My message is very simple with pediatric patients, but let me just share some of my things that we do routinely here for pediatric patients. So this is my relevant conflict of interest. This is something we don't want to see, right? I mean, this is something we should avoid at all cost. I agree, sometimes we say that low-dose CT is possible and we might be able to do it. But I would say, remember the principle, as low as reasonably achievable. And for pediatric patients and maternity, it should be negligible, really. So let's see what the guidelines have to say. Ultrasound is the first-line imaging modality in children when a stone is suspected, and it should include the kidney, fluid-filled bladder, and the ureter. And a KUB load or the non-contrast CT is an alternate if ultrasound doesn't give you the necessary information. So how can you get the necessary information? And I'll come to that shortly. So let's talk about ultrasound scan. Well, we know it's no radiation, no anesthesia, fluid-filled bladder. You can see the anatomy of the ureter and the upper ureter to look for hydronephrosis, etc. Color Doppler can really help in the ureteric jet and the resistive index, especially around the arteries, which can be indication of obstruction. Clearly, you probably need trained people to do it. Now, this is just to show you, this is hydronephrosis in a 4-year-old male. This shows the left ureter. So again, I think user experience is quite important. And again, this shows the left ureter with a large stone in it. Let's look at another patient. These are patients from our own hospital that we've recently operated last month. This is a few months ago, 3-year-old cystine stone. Again, you can see a large, almost 1.7 centimeter renal pelvic stone. Same thing here again. This was in April. But when we went to operate on the patient, I thought the stone was a lot larger, and you can see it's filling whole of the pelvis. So sometimes you can get thrown off by the ultrasound scan because, again, it is not completely as accurate as you'd want it. So with this patient, we had a 2-stage ureteroscopy, for example, for the cystine stone. So let's have a look at how to investigate renal calculi. So how do renal calculi appear on an ultrasound scan? They are bright, dense hyperechoic areas. They have posterior caustic shadowing and a twinkling artifact, which can help with the diagnosis. Now, what are we looking at? We are looking at site, size, and number of calculi, presence of obstruction in form of hydronephrosis or hydroureter, and then the renal corticomedullary and renal cortex differentiation. Does it look okay or not? Now, looking forward, so what is the downside? The problem is up to 40% of calculi can be missed by an ultrasound scan. Although they can give you the anatomical location and the pelvic-cholesterol dilatation, but you may not find the calculus. So you might have to rely on indirect judgment. And then from the adult literature, we know that quite a lot of stones will also be missed on plain film because some stones will be really recent. So that's why the reliability is less, and also the presence of bowel gas shadow can sometimes make things even more difficult to interpret. So really in pediatrics, you have to be a bit more cautious. Now, I think ultrasound and or KUB X-ray is adequate in most patients, as we have just listened to the various talks that talked about the follow-up imaging, and I think that's no different here. Really, it is in very selective cases where you need for treatment planning or diagnosis in complex cases. So we, especially even for PCNLs, we don't routinely do it. But if there is a anatomical anomaly or something like that, then we might do it, because to give us a bit more information around the anatomy in the abdomen. And of course, if you can, then you can consider an ultra low dose CT, which is even better. So, 1 millisieverts or less. Metabolic workup, don't forget, although we are talking about imaging, metabolic workup, absolutely mandatory in pediatrics, because up to half of them will have a metabolic issue. What other imaging can be done? IVU, but then you need contrast medium, not great. MRU, you can do an MR urogram, but again, it is not easy to diagnose stones, although it can give you some idea about the anatomy, obstruction, and parenchymal morphology. We hardly do it really. And DMSA in really highly selected cases, if you want to look at the split function, again, not commonly done unless they are nearing sort of adolescent, sort of age group, 15, 16, 17. Let's look at radiation protection measures. What do we say in the guidelines? So you have to limit your studies or intervention that involves radiation exposure. And that is not just imaging wise, but also during and after your procedures. Implement a patient electronic record of medical imaging, so you know how much radiation they've had. And make sure you do it with as low as radiation as possible. Have a protocol in place, so last image save, etc. when you're using a C-arm. Measure and report the fluoroscopy time, because again, this is important for the patient, but also for the surgeon. Now, it is well and good to say move aside, or do what is best. But actually, you need a team to do what is best. Otherwise, just moving aside can put you in trouble. So although we are saying ultrasound is a must, but you must have somebody who is dedicated for imaging in pediatrics. Ultrasound pre and post-op, agreed. Trained person, I think this is quite important, because you don't want not an unskilled, but a less trained person to do, especially in this age group. And it will be even more ideal if you can have a same person doing it. So this for the purposes of continuity, because they might have their own way of doing it, and they can then identify very small stone growth, because as we know, it can be user dependent. And if in doubt, you can consider a ultra low dose CT. And ready for the questions. But I think, remember, in pediatrics, it's even more important, because they will have recurrences, they will have further stone episodes, etc. And you must rely, because these are patients who will keep having stones, keep having colics, and it is even more fundamental to keep the radiation dose as low as possible. Thank you, everyone.
Thank you so much, Bhaskar, for, as expected, a very nice and excellent presentation. Bhaskar, what do you do in your everyday practice? You are dealing with kids, you are operating a lot, and I would add what you are doing preoperatively, intraoperatively, because I mean that was not the topic for this talk, but also postoperative. And yeah, that's the first question, sorry. And the second question is really the follow-up of children different to the follow-up of adults? And if yes, in what way? I mean,
so I'll say the first question. So pre-op, we always do an ultrasound scan, and now we get a referral from a very large area in the UK, all of South and Southwest, up to 206 miles, So sometimes patients would have had a pre-op CT, they would have done it, especially if they're kind of between 14 and 16, but we never mandate that. And we hardly ever do that unless it's a complex anatomy and we are planning for PCNL. If I'm planning for ureteroscopy, it's very rare we'll get a CT. Intraoperatively, we work together. Again, we have a dedicated fluoroscopy radiographer who will be doing it, and we try and minimize the radiation as low as possible. So like when I'm using the ureteroscopy or stent, we just do one image at the end just to confirm the stent position, let's say, for example. Post-operatively, again, it's ultrasound, but I have to mention here, we have a pediatric and a stone MDT where we discuss pediatric patients, so that the radiologists are involved in that case. The imaging, usually if a patient comes, we always try and image them the day before or the morning of surgery, mostly, so that the imaging is most up to date by a dedicated person. So if the stone has changed because there's a 3-month delay or whatever, and I have been caught out once or twice when they said the stone, but it was much smaller than what was mentioned. And we were planning for PCNL, but we changed to something else. The second question, Andreas, I've forgotten now. Sorry.
Sorry, the second question is the follow-up of the pediatric patients,
Yes.
different to the adults. And we have a similar questions from the audience. How long do you follow the pediatric stone patients is a similar question, actually.
So actually, in some ways, the guidelines are doing now for adults what we've always done for pediatrics. Pediatric patients, we always have a more rigorous follow-up and for much longer, because it's only a question of time when they make a stone. They will make a stone, and the recurrence is very, very common. So I would say for pediatric patients, we normally do an immediate post-op within 6 to 12 weeks ultrasound scan. And if it's a parent hospital, they will then follow up every 6 to 12 months. But then it's depending on their protocol. We would like to follow them up at 6 monthly intervals going forward, but it's always ultrasound scan for us.
So
now, in terms of
sorry.
And in terms of discharging them, I mean, I have to say we hardly discharge them till they have come to the adolescent practice and so on. And then we treat them like adults, but these are patients who really need a very long-term follow-up. But yeah.
So, Bhaskar, can we say, I mean, Dr. Hiron had raised this question for us tonight, and for the rest of the audience. I think we have it already in our algorithm, the consensus that we did as a panel, because by definition, the children are belonging to the high-risk stone, high-risk group for stone recurrence. So high-risk stone recurrence patients, they do need a metabolic evaluation and long-term, as we say in our algorithm, long-term follow-up. Of course, imaging for children is ultrasound most of the time. But yes, I fully agree that you cannot actually discharge. I do have another question for, we can all of us reply to questions. There is one more question, Bhaskar, not for you. The question is, what is the limit of the fluoroscopy time for the patient and the surgeon? So I will reply to this question. It's not a limit of fluoroscopy time. There is not such a thing. It's a limit of the radiation dose exposure per year that you can have, which is actually, it's actually very important not to go above the 50 millisievert from for the annual dose exposure. So you have to calculate your exposure as urologist, because it's very important. Believe me, it's very, very important. Now I have the pediatric PCNL fluoroscopy is used for guided puncture to reduce, and or ultrasound guided puncture for PNL for reducing the radiation exposure. Of course, Bhaskar, what is your reply?
Yeah, do you know, if you're doing pediatric PCNLs, my view, and it is my view, you should always have an ultrasound scan, and really that helps limit the radiation dose quite a bit. So we always have a team up with the interventional radiologists. Always, majority of till the puncture is done is with ultrasound scan. Once the needle is in, to confirm and to pass the wire, that's when we use the fluoroscopy to pass the wire in the bladder. Till then, most of that is done by ultrasound, both actually in adults and pediatrics. But I think for pediatrics, it's even more important that you try and combine it together for two reasons. One is the radiation dose, of course. The second is the anatomy might be slightly different. An ultrasound scan might help you with visualization of the bowel, etc., more clearly. Because remember, we don't always have a CT scan for them. If you don't always have a CT scan, you don't want to have an increased risk of complication. An ultrasound really will come in handy.
Okay. And I know that you have already replied in one interesting question. I have already replied. Is it the low dose CT scan for follow-up or the ultra low dose for following up our patients? As we said, just to reply this for the rest of the panel and the audience, we don't recommend following up with regular CT scans unless there is a need for intervention. But when we use CT scan is the low dose CT scan. The ultra low dose in patients that are slightly obese, they may lose some stone. So low dose when needed is recommended. Bhaskar, do you think differently?
So that's what I wrote in the comment. If it gives you the information that you're looking for, you can go ultra low dose, but you don't want to miss out on important information. And the principle is ALARA, as low as reasonably achievable. But giving you the clinical data, you don't want to miss out on some important information. So I agree, low dose is for most people. But if, for example, I'm following a stone, ureteric stone, and you know that you already know where to look for, then for a follow-up, and if you X-ray and ultrasound cannot help, then you can go ultra low dose because you know exactly which area and what you're looking for, but taking into account the BMI, etc.
Okay, and Rob, I have an interesting question for you. Which imaging modality we recommend as panel guidelines for those people that we treat conservatively for the first episode of small, less than 4 millimeters ureteric calculi? When should we image these patients, Rob?
That's a really good question. So obviously we're assuming that they presented with colic and they've had their low-dose CT to confirm that diagnosis. It's good practice to get an X-ray at the same time so that you can confirm if the stone is radiopaque or radiolucent. And then you would follow them up as per their symptoms, and if the stone is radiopaque, I would then carry on with an X-ray, because you can then see if the stone is passed or not in conjunction with their symptoms. If the stone is radiolucent, then that's slightly more complicated. You could use an ultrasound, but we know that ultrasound in the ureter, and specifically the distal ureter, is not all that brilliant. So you could then think about ultra low dose CT in the right sort of patient.
Yeah, Rob, I think I have already replied typing this question because we had it twice. I think with radiolucent stones, there is always a problem. But the patient's symptoms really guide you. An ultrasound with no hydronephrosis is really guiding us. And of course, to some extent, during the follow-up of our patient, if there is any doubt, of course, scanning the patient, but not the whole body, low-dose CT scan. And if the stone was in the lower part of the ureter, you can scan also only the lower part of the body, which I think is a good way to think, so as not to expose our patients to a lot of radiation. As we said today, the relation of radiation and cancer development is not dose dependent, unfortunately. So all the other teratogenic problems are dose dependent, and very rarely, we go beyond the threshold of the radiation cutoff limits to have teratogenic or other burns or whatever from the radiation exposure we do during the follow-up. But the carcinogenic effect is really something that we don't know how much. And you have to remember that already the patients, before being followed up, before that, they have been already exposed to a lot of radiation for the specific stone, but even for the radiation in the radiation exposure for the previous life they had. So we have to consider, one good way to think is to document the radiation exposure per patient, but I think we are a little bit far away from that. So guys, to finalize, we have another question, interesting question. Of course, it's not about the follow-up. Is it an X-ray, KUB, or CT scan at the emergency department? Well, it depends on a lot of, this is not the topic of tonight's talk and webinar, but of course, it depends on many issues. Clear cut is, there is not an answer. During night times, you may not have access to a CT scan, let's say. Of course, the CT scan, I would say, is recommended if an intervention is needed. So thank you all, guys. I think we are coming to an end. Thank you.
Andreas, Andreas,
Yeah.
just one more point on the emergency. If the patient is unwell, you might even consider a point of ultrasound scan. You know, some emergency departments to look for infected hydronephrosis can also do that. So as Andreas said, target the emergency imaging at the time to whatever is available at your, at your disposal.
Okay. And Bhaskar, the last question, because as we stay, questions are coming through, which is good. Now, let's say that I have a patient that he's on renal colic, he had spinal fixation, and the CT scan does not work because, I mean, you cannot see. There are a lot of artifacts there. What would you do? Of course, this is not a question about the follow-up. It's about the initial
diagnosis.
The initial diagnosis.
I think so. You have a patient, and the principle is first do no harm. And if you don't make a diagnosis, you will do harm to the patient. So this might be a situation where you might want to use a contrast CT urogram to delineate and see if there is any obstruction, because you need to make a diagnosis, whether there is a stone or not. Or you have to consider, because MRI will have the same issue. You'll have an artifact from that. So you have to judge it. But I would say this is the time to go to the friendly radiologist, show them that, and get their opinion on what to do next, because ultimately they will be doing that kind of scan for you. But I would say this is the situation where you speak to your colleague and get the best out of it.
Okay, so I would like to thank the whole panel for being here with us tonight. I think we are quite proud, actually, guys, that you are listening to us tonight about the work we did within the guidelines regarding the follow-up of the stone patients, because if you see the literature, there's nothing out there, and or there are very little out there. And this is the very first time that was done under a systematic review of the literature, which I think is very important. I would like to thank everybody. And I think we are coming to an end of this webinar. Thank you very much for listening to us and watching us tonight. And we really appreciate your presence.
Thank you, everyone. Bye.
Thank you. Goodbye.